In episode 2, we examine what happens next, the differential, the escalation decision, and what changes downstream when the decision comes early versus late. Because when synovitis persists, biology does not pause. If you were building a short kind of Monday morning checklist for sports medicine clinics to avoid treating TGCT like a sprain for too long, what would be on it?
Yeah. So I'd say number one, atypical or atraumatic joint swelling is one. Two, the symptoms are not improving with conservative measures. Three, the swelling does not match with a particular activity or injury pattern, right? We know for ACL injury, there's a cutting motion and the knee twists and they feel a pop. Or for someone with shoulder dislocation, it's very obvious, right? They know their shoulder dislocated. But for more occult mechanisms or really no mechanisms at all, that's another item that's on my checklist. And then honestly, if they haven't had an MRI, right? If they haven't had the MRI, I think you just gotta say, all right, that's the fourth thing, no MRI. Just get an MRI, cross it off, get a diagnosis.
4 items. 1, atypical or atraumatic joint swelling. 2, symptoms not improving with conservative measures. 3, swelling that does not match a particular activity or injury pattern. No cutting motion, no pop, no clear mechanism. 4, no MRI yet? Get the MRI. Since becoming more aware of TGCT and other rare joint tumors, what are 2 or 3 concrete changes that you've made in how you evaluate or follow athletes with those persistent joint complaints?
Yeah. So I think spidey sense is a big thing, right? So I've learned over the years to trust the spidey sense a lot more, as Dr. Randall's told y'all. I think starting off when you're in training or in practice, everything's by the book, right? Like, this is what I learned, this is how it should present, this is what it should be. And you find out in the real world it never works like that. Everything is gray. There's very little black and white. And so you kind of have to, I think, trust yourself and the intuition that you have, and knowing that not everything's going to be exactly by the book. And then the other thing is, I think another piece of advice is probably just, again, don't hide your head in the sand. Don't be an ostrich. I know that I've been using a lot of sayings today, but
They're great.
if if you have something that is not really getting better, and we just kind of say, oh, it's fine, it'll be okay, and just keep treating it with XYZ conservative measures, then you're just burying your head in the sand. You're not actually addressing the problem. And so that's another thing that a few of my mentors in residency would always tell me, that, if you just got to face everything head on and not just push things off to the side. So those are probably the 2 biggest things that get you in that mind frame to think about what are these more rare diagnoses, and how do we treat them if they pop up?
2 things. First, trust your clinical intuition. Early in training, everything is by the book. In the real world, everything is gray. When something does not feel right, it probably is not. Second, please don't bury your head in the sand. If something is not getting better and you keep treating it conservatively, you are not addressing the problem. You are avoiding it. How do you involve athletic trainers, physical therapists, coaching staff when you decide to change course from rehab of an injury to the kind of conversation, we need more imaging or specialist referral? How do you make that shift?
I think that a lot of those members of our team that you just mentioned are our first line responders, right? So they are the ones who are seeing our patients, our athletes, on a much more frequent basis than we do in the office. And so I think it's imperative to involve them in conversations around patients, and they are the ones who can kind of let you know, hey, I've been seeing Tom's knee is not getting better. this is what I see on exam, and when I'm with him in physical therapy, what do you want to do, right? Because that really helps us to kind of keep tabs on everybody. And so those, those, again, quote, first line responders for us as sports medicine physicians are incredibly important within our team to kind of make sure that we're not missing things and giving patients the timely and excellent care that they need. In terms of when we're now kind of making that transition from rehab to treatment of something like TGCT, I still think it's really important to involve them because while as surgeons, let's say I'm going in to debride someone's knee for do a synovectomy for TGCT, right? That patient's still going to need rehabilitation afterwards. That patient's still going to need people who are helping to support them. And while I do see patients in the office for regularly scheduled visits, they're more likely to see a lot of those people like physical therapists, athletic trainers on a more frequent basis who, one, help them recover, but two, also are kind of their biggest like cheerleaders, the ones who kind of help them progress and say, hey, let's get you back on the field, let's get you back doing things. And so I think when I have any sort of diagnosis that I'm sending somebody to a physical therapist or an athletic trainer for, I keep in contact with them. I text them, they text me, they let me know what's going on, and I can kind of help to shape their mindset about how they're treating that patient, so that we can really get that person in the right physical but also mental headspace to be on the road to recovery.
Right. And they're some of the first people who might actually see and hear about this.
Every time, yeah. Sometimes they even see they've seen them before they come to me, and then they say, get a text like, "Hey, this seems weird. What should we do?" And I say, "Get an MRI." That's usually my first answer.
Athletic trainers and PTs are first line responders. They see athletes far more frequently than the physician does. They text him, "This seems weird. What should we do?" His answer is almost always, "Get an MRI." And these team members are the early warning system. Involving them is not optional. What are the key barriers that keep sports medicine focused on common injuries, even when the case is not following the usual script?
I'd say the biggest things are we don't expand our mindset to think about what are the more rare diagnoses that might be missing, like we kind of touched on earlier. But I think too, there's a time element, right? So I mentioned this in the previous answer, but it's as a orthopedic surgeon, you're expected to see X amount of patients in X amount of time in order to meet X amount, whatever quota you're supposed to meet. And so that commonly, at least for sports medicine, involves patients having 15-minute clinic visits, right? And that's tough sometimes to really suss everything out in a 15-minute visit from a patient, but it's also sometimes difficult for the provider in that setting to think, okay, this is the more rare diagnosis that I wouldn't normally expect. So that time element, while it's hard to eliminate, I think we get through some of that by, again, increasing awareness and increasing the knowledge of people, sports medicine surgeons, non-operative sports medicine providers, and basically everybody involved in that field so that we can really get people diagnosed properly.
Two barriers. First, the mental differential does not expand. Sports medicine is trained on the common, and in the time-pressured reality of 15-minute visits, the rare does not surface. Second, volume and pace. But awareness is the countermeasure. Increasing the knowledge base changes the default even within those first 15 minutes. Dr. Freshman's checklist gives the frontline a framework. But what does the orthopedic oncologist see when that framework is not applied? When the patient arrives after months or years of conservative management? Dr. Randall returns to describe what delay costs at the system level. If you were designing a one-page TGCT checklist for sports medicine clinics, what key items must be on that list?
Well, I like to keep it simple. So, clinical triggers. So, persistent monoarticular. There are cases, just a quick side note, where it can be in two sites. It's not metastatic when it's in two sites. It's exceptionally rare if it's two sites, but just for our audience to realize, it's usually a monoarticular problem. Where there's swelling and stiffness, it's progressive. We have the discordance of the history, not lining up with what the journey is of the patient, recurrent effusion, some mechanical symptoms, that trigger point, and then the trigger point of imaging with the blooming artifact, the hemosiderin. 1 + 1 is 3, meaning the third point here, that they need to call up the orthopedic oncologist. So that's my checklist.
He keeps it simple. Clinical triggers, persistent monoarticular swelling and stiffness that is progressive, discordance between the history and the patient journey, recurrent effusion, mechanical symptoms, imaging trigger, blooming artifact, hemosiderin, and then 1 + 1 is 3. The third point is they need to call the orthopedic oncologist. That is my checklist. What have you learned from running fellowships and AYA programs that could help us teach TGCT recognition in a way that actually changes practice?
So in terms of learning and training fellows, I've come to appreciate that people like to hear stories. So I try to create vignettes or anecdotes with trainees around the 22-year-old basketball player who was noticing an insidious onset of knee swelling but didn't have an injury, things of that sort. They like visuals. We're surgeons. We like to see imaging. We like to see intraoperative photos, things of that sort. So we try to have a lot of visual content. And then as relates to the AYA aspect of it, it's about communicating. And one of the most important messages I try to have for our fellows is it's the tone that makes the music, that you need to really be understanding that these patients are really disadvantaged because they're dealing with an orphan condition, and they've probably seen a lot of super well-intended and super well-trained providers who have no clue about their condition, and they're coming in a state of heightened anxiety, and you need to manage that as well. So again, just to recap that, we want to tell a story to our trainees. We want to give them visuals, and that they need to be compassionate in their communication.
People learn through stories. He uses vignettes. The 22-year-old basketball player with insidious knee swelling and no injury. Surgeons like visuals, imaging, intraoperative photos, and for AYA patients, the communication itself matters. These patients have seen well-intended providers who have no context for their condition. They arrive anxious, and compassion is not optional. If a sports medicine physician listening to this series only remembers one concept from you, what should it be?
If the history doesn't line up with the potential diagnosis, then, and the chronicity of 3 to 6 months, that's where we need to ask the sports community to take pause, reboot the thinking, and be considering now TGCT.
If the history does not line up with the potential diagnosis, and the chronicity has reached 3 to 6 months, that is the moment to take pause, reboot the thinking, and consider TGCT. Dr. Randall describes what delay costs from the surgical perspective: narrower options, harder procedures, longer recovery. But TGCT is increasingly managed across multiple disciplines. To understand what the downstream care pathway looks like and what earlier recognition preserves, we turn to medical oncology. Dr. Carr Asher is a medical oncologist and physician scientist at UC Davis, specializing in sarcoma and soft tissue tumors. She treats TGCT within a multidisciplinary framework and leads a research lab studying sarcoma biology. She sees patients after the diagnostic journey, sometimes a short one, sometimes measured in years, and multiple surgeries. And she brings perspective on how the length of that journey shapes what is possible. Dr. Carr Asher, thank you for being part of this conversation. From a medical oncology perspective, why does a diagnosis like TGCT, technically benign yet locally aggressive, still demand real urgency in recognition and referral?
As you mentioned, it's benign but aggressive, and I think that that's really important to keep in mind because, this disease doesn't spread and become life-threatening, but it does have huge impacts on people's quality of life. And so getting people to the right providers that can really have a lot of these nuanced discussions and conversations to help guide people's treatment is really important. Because these patients are young and have 50, 60 years in front of them, and the reality is they're going to have to manage this disease for all of those decades, right? And so it's really important to make sure that we're really providing the most conservative, but at the same time the best treatment to kind of ensure that they have good quality of life for as long as possible.
TGCT does not spread and become life-threatening, but it has enormous impacts on quality of life. These patients are young, with 50 to 60 years ahead. They will manage this disease for decades. Getting them to the right providers for nuanced multidisciplinary discussions is essential. When TGCT patients finally reach medical oncology, what common diagnostic journeys do you hear, especially from active or athletic individuals?
Yeah, I think the most common story that I hear is, oh, I tweaked my knee, when I was playing soccer, and ever since then I've had this joint swelling, right? It gets worse every time I play, and I have to ice my knee all the time. I'm always, sort of limping along in between practices and things, and so I hear this frequently where they can sort of tie their symptoms to an acute event sometimes, which I think makes it a little bit more complicated to diagnose because, if you are 20 and playing soccer, it is very feasible, right, that you tweak your knee and you have swelling after that. And I think it makes it a little bit harder to diagnose in that case when people tie it to a specific traumatic event. And then I think I hear a lot about, people have often gone years with this disease before they've seen me. And they've had multiple surgeries. I have seen people who are in their 20s and 30s who have had 7 or 8 surgeries for this disease. And so oftentimes they go through these long courses before they're referred over to see me or to see orthopedic oncology.
The most common story is perhaps I tweaked my knee playing soccer, and ever since then I've had this joint swelling. Tying symptoms to an acute event makes diagnosis harder, though. And by the time they reach oncology, many have gone years. She has seen patients in their 20s and 30s who have had 7 or 8 surgeries before referral. How does a diagnostic delay of 17 months or longer change the complexity of the treatment you're planning?
Yeah, I think the delays are important to keep in mind because what I've learned from my orthopedic oncology colleagues, I have to say it's not within my expertise personally, but these patients, as the joint goes on with this inflammation, right, it does lead to damage within the joint space itself, and so patients can essentially develop an arthritis, right, in that joint. And the other thing is when you have a long-standing joint issue, let's say in the knee, I've learned that it affects the way your ankle functions, right, in your hip, and you may have additional pain or symptoms associated with that. And so the longer time that goes on, right, the more likely you are to accumulate some of these other morbidities. And so even once you treat the TGCT, it may take quite a lot to get that person back to their baseline. So I think getting them linked in early and addressing this early if it is causing some of these mechanical issues is really important.
Long-standing inflammation damages the joint. Patients develop arthritis within the joint space, and the effects cascade. A knee problem alters how the ankle functions, how the hip compensates. Morbidities accumulate. Even once you treat the TGCT, returning the patient to baseline may require far more than addressing the tumor itself. When you counsel a patient who is newly diagnosed versus one who has had a long course, how do the conversations differ?
Yeah, I think this is where that time to diagnosis comes into play, right? Because for people who have had a long course already, unfortunately, I don't always expect them to get fully back to their functional baseline, right? Especially if they've had a lot of surgeries before, they have a lot of arthritis or other joints that are bothering them. Then oftentimes I'll tell them I think your symptoms will get better, right? I don't know if you'll get back exactly to where you were before, right? But oftentimes people have a lot of swelling in the joints, right? These joint effusions that can happen, and oftentimes that will get a lot better, which in effect, leads to less pain, less discomfort, right? And so people will be able to be more active. And I usually tell them, if you're starting a systemic therapy, my expectation is that within a few months, you should really notice a difference in the symptoms. The mass may not be changing, right? The tumor may not change on the first set of imaging. It may take quite a bit longer to actually see improvement on the scans, but we really are following clinical improvement. Anyway, that's really what's driving treatment decisions. Is really the clinical improvement. And so I do expect to see that in the first few months, and that's because we do get, stoppage of that CSF1 pathway and less of that inflammation. And so oftentimes people will notice, in a relatively short period of time that they'll see improvement in their symptoms. But I think those patients who come early, right, who just got a new diagnosis, haven't sort of had a long course already, oftentimes you can get them back to kind of where they were and close to 100%, with systemic treatment or sometimes a combination with surgery or surgery alone. But they tend to do much better when they haven't kind of already had a long course in terms of the systemic therapy, right? I expect people to do much better if they're sort of newly diagnosed.
Newly diagnosed patients, short course, no prior surgeries, can often go back to close to 100%. But patients with a long course, prior surgeries, and established arthritis, or unfortunately, I do not always expect them to get fully back to their functional baseline, the length of the diagnostic journey directly shapes what is achievable. One word recurs across this episode: progression. TGCT does not metastasize, but it progresses locally. Inflammation accumulates. Synovium proliferates. The joint changes. Treatment conversations evolve from simple to complex. The inflection point often occurs before referral, when the expected recovery curve flattens, when duration outweighs mechanism.